Hello guys, hello family, hello friends. This is Dr. T and welcome to Clinical Medicine with Dr. T. So guys, in this video we're going to be talking about hyponatremia. Hyponatremia. So I would urge you guys to go back and watch there's about 6 videos that I uploaded where I discuss body fluids, fluid compartments, electrolyte distribution in the body. If you can understand those videos, it's going to be easy to understand the concepts that we're going to be talking about now. Otherwise, if you struggle with those concepts there, it's going to be difficult for you to understand hyponatremia. Hyponatremia is not easy. It's not easy, but you will say it. So, yeah. So hyponatremia, you can suspect it from a patient based on the signs and symptoms they are presenting with, but you will still need hyponatremia, but you still need blood tests to confirm the diagnosis. Hyponatremia is very common. It's very common, but the severe form of it's not so common. Remember, hyponatremia can be mild, moderate, and severe. As we can remember from the previous videos that we have done, when we talk about hyponatremia, we are talking about sodium level in the plasma that are less than 135 millimoles. Because normal is 135 to 145. I don't wanna start talking about sodium being the most abundant extracellular cation, because in those videos we've discussed that. So yeah, that's why it's important for you to go back there first. But now the severe form of hyponatremia is when you've got a sodium that is less than 127 in the plasma, right? So hyponatremia, you can suspect it based on the signs and symptoms that we're going to be talking about, or it can be a finding so you can just discover about it when you do UNEs. So we do UNEs for many things, so it can be a surprise finding. The patient is not symptomatic, and then you just do, maybe say we are admitting a patient for operation, and then bam, you see hyponatremia on their UNEs. So it is common, but the severe form of it is not very common, I must say. So when you've got hyponatremia, what are the signs and symptoms that the patient might come in presenting with? It's mainly CNS symptoms, such as headache, they can come in with dizziness, they can come in with seizures, they can come in with they can be irritable or restless, or they can even come in coma. The musculoskeletal symptoms that they might also come in with is just generalized body weakness, appearing lethargic, right? So those are the symptoms that you expect, right? Now, your approach to a patient who has got hyponatremia, in terms of you want to know the cause so that you can know what you need to treat. So you will have your hyponatremia. The next thing that you need to figure out is the osmolality. You can calculate it. I'm going to show you how to calculate osmolality. You can calculate osmolality of the plasma. That calculation is going to classify the hyponatremia for you. So osmolality. Osmolality can be low, normal, or high. The normal range of osmolality is between 275 to 290 osmoles. So if it's more than 290, then by definition that's hyperosmolality, or we can say it's hypertonic. Then if it's low, it will be less than 275, right? Now, let's talk about hypertonic hyponatremia, because that's the diagnosis that you have this side. You have hypertonic hyponatremia. So you've got a patient, they've got hyponatremia, and you calculate their osmolality. You find that they have got an increased osmolality. Then that's hypertonic hyponatremia. Why would someone who's got an increased osmolality develop hyponatremia? Now that's the question. I'm going to draw here a diagram that I have been using ever since I started this series. So this is our blood, this is our intravascular. There's plasma inside there, and then these are our cells, right? By now we know that this is our intracellular fluid, and this is our extracellular fluid or interstitial fluid, and this is our intravascular. Or our plasma, right? Now we have discussed the factors that are responsible for moving fluid from the intravascular into the extracellular, and the ones that bring it back, those forces that we were talking about. We also know what causes water to leave the cell or go into the cell. We have spoken about that in those videos. Now, when you've got a high osmolality, It means that you have got a lot of solutes, a high concentration of solutes in the intravascular space. But we know that if you take a blood sample from the intravascular, whatever that you find on the result is what is happening in the interstitial. That's what we know. Because your concern is you want to create an environment that is conducive, that is favorable, that allows this cell to function. So the fluid that is around these cells should always be under check so that these cells can function the way they are supposed to function. So that's why we are concerned about blood tests and checking and checking and checking. So when you've got a lot of solutes or a lot of osmotic active substance inside here, when you take a blood test, this is what you are having as well here, because remember, there's a constant movement of fluids from this side to this side and from this side to this other side. So the amount of whatever solute you're looking at here is the same as here, right? Except for the substances that do not cross the endothelial wall. Okay, so now when you've got hypertonicity in the extracellular fluid, we know what that does. What that does, it causes water to leave these cells. So water will start to leave these cells. And because there's sort of like a uniformity between the extracellular and the intravascular, water will get into the intravascular space as well. Right? Now, remember from our previous videos that the total fluid or the amount of water that we find in the intracellular space is about 28 liters. 28 liters. Now imagine if all those cells now they start releasing their water, and then the water comes to the extracellular and then into the intravascular. So the sodium that is here will be diluted. That sodium will be diluted. So that's the one word that you need to remember, guys. The sodium is diluted, such that if you take a sample to the lab, it's going to appear as if, when they do the test, it's going to appear as if you've got a low sodium in that sample. It's not because you have lost sodium, but it's because you have diluted the sodium, because the substance that is inside here is osmotically active. It's able to draw water from the surroundings. Now you have diluted your sodium, and now it appears as if you've got hyponatremia. Now, what are the substances, the common substances that can give us this hyponatremia? So, hyperglycemia is the most common. Hyperglycemia is the most common. So once you've got hyperglycemia from DKA, from HHS, from HONG, so what's going to happen is that you've got glucose that is inside here, that is osmotically active. Now it pulls water from the cells into the intravascular. Now you are diluting your sodium. That's why some people call it a dilutional hyponatremia. Another cause would be mannitol, which is a diuretic, very potent diuretic. Another one is glycine. Recently, I've had a patient presented at the clinic with seizures who had a hyperglycemia, and after the fluid status was corrected of the patient, given normal saline and all that, patient never had seizures again. So it's very, very common, guys. It does happen, right? So if you've got a patient who's got seizures and they've got hyperglycemia, think about hypertonic hyponatremia as one of your differentials. Hyponatremia is known to cause seizures. That's why part of your wake-up when you've got new onset seizures, you do UNEs. That's part of the wake-up. So guys, it's very important. This is going to be our part 1 of hyponatremia.